in Oxford. It gives me great pleasure to introduce my colleague, Radu Mihai, a great colleague who's got a reputation amongst the general surgeons as somebody who's extraordinarily nice and a very good surgeon, which is not usually the normal combination. He's going to talk to us this afternoon about multiple endocrine neoplasia syndromes, an important but rare set of syndromes which you may have come across, and some you will not. Truthfully, as a surgical trainee, it was a subject that I struggled to get my head around sometimes, but this is a subject that Radu has expertise in and familiarity of, and I think we'll learn a lot over the next 20 minutes or so. If you have questions, please use the Q&A function at the bottom of your screen. Some questions, if you think they're particularly good, then give a thumbs up, and then we'll select those questions at the end. So without further ado, I'll hand you over to my colleague.
Good afternoon, everybody. I want to start by thanking the College of Edinburgh, with whom I had no previous interaction, for inviting me today. I think it's a great initiative, and these troubled times have forced us to introduce these new techniques. I like to see the audience to gather the interest or the reaction to what I say. So this artificial environment might make the presentation a bit dull, but certainly I'll do my best to keep you entertained. 20 minutes of multiple endocrine neoplasia. So I want to start by saying that anything we learn in medicine at your young age should be like a big tree. You need to identify the big branches that might help you in case you fall or you're in a panic. The details you will discover later in your training. And so for today, I'll try and stay on the very broad concepts of this. For those of you who might want to go in endocrinology, probably my talk, it's not enough. For those of you who will stay away from surgery and endocrinology, maybe my talk, it's a bit over the top. So first of all, what are these syndromes? Multiple endocrine neoplasia. It's a group of conditions that have been observed to occur in patients who develop more than one tumor in more than one endocrine tissue. They develop such tumors quite early in life, and when they get them, they multifocal. So the story happened in the 50s when Dr. Verma first found one such combination, and a few years later, Dr. Siepel found another combination of tumors. And so the numbers come up, MEN1 and MEN2, in the order of how these syndromes been described. As time went by, more details came up, and then MEN2 was divided in 2B and 2C. And more recently, some people describe MEN3 and 4, of which I won't even touch today. We will stay on the first two numbers, MEN1 and 2. So the story starts with this doctor observing a patient who had more than one parathyroid tumor, developed pancreatic islet cell tumors, and a pituitary tumor. So it came to be known as the 3 Ps, parathyroid, pancreatic, and pituitary. And more patients being recognized, other tumors being apparent, that such patients might also get adrenal or thyroid or lipomas or meningiomas. But the definition and the easy mnemonic for this MEN1 is the 3 Ps of the parathyroid, the pancreas, and the pituitary. It's an autosomal dominant, so if one parent has it, the children have a 50-50 chance to get it. And that's important for the advice you give to such patients to understand when they start a family, what this will involve. It has 100% penetrance, but it's a huge variability of expression between members of the same family and between families that have the same condition. The gene was located on chromosome 11. At some point, somebody discovered, then some laboratory study proved that this is a tumor suppressor gene. So you need to have some loss of heterozygosity, it's called, in this region. You need to get another hit in the gene for this to start to trigger the tumor formation in different organs. The difficulty with this menin gene is that there are over 1,300 mutations reported. So it's very difficult in a laboratory to identify these mutations being so many, and if you can't find any mutation in the menin gene, maybe this is a patient with some mutation that has not yet been described. 1,300 was the count a few years ago. I won't be surprised if now the count moves towards 1,400. So what these people get is, first of all, parathyroid tumors, and this is in the vast majority of patients. About a third of them get neuroendocrine tumors, and half of them get the pituitary tumors, and the rare arrangements we don't even comment today. So parathyroid is the most common condition in MEN1. Most of them are diagnosed on screening patients that are known to belong to one such family. But at times, and this is where medicine has its more spectacular, is if you encounter the first patient of that family and you suspect him to be an MEN1, and you initiate the process through which you demonstrate, because if you do find a new family, that diagnosis in one patient and has a lot of bearing on the management of many other members of his own family. These people get disease in most of their glands, and I put 3 slides from 3 different patients just to show that the development of tumor is a bit asymmetrical. This first patient had quite a large left superior parathyroid here. The inferior glands were pretty big, but the biggest one was in the thymus, and lower down here, this is the thymus that is excised. And with the operation, you always excise the thymus, because you will remember from embryology that thymus and inferior parathyroids grow together. So at times you can have parathyroids within the thymus, such as it was in this patient. And these MEN1 patients can get tumors in the thymus. So it's asymmetrical, but it's in all glands throughout their lives. And this is why, as time moved on, and now we identify these patients younger and younger, there is a debate in the surgical world if the children of these families could just have one side of the neck operated and leave the other side for later, because not all tumors develop so early. So if a child develops hypercalcemia, it's quite likely that he has only 1 or 2 of the glands affected. The other is going to be affected later in life. And because this is a lifelong condition and is not killing you, but it creates troubles throughout life, it's very important, this counseling of the patient about the timing of the intervention, when to do it and how much to do at each of these operations. The pancreas is more spectacular because it relates to some syndromes that would be very much discussed in medicine, though some of you might hardly ever encounter any such patient. The most common of them is gastrinoma, tumors producing too much gastrin. These are tiny tumors in the gastrinoma triangle, and those with an interest can Google later on and learn about this gastrinoma triangle. The insulinoma, it's a very difficult diagnosis at times because the symptoms are so vague and confusing for a long time. These are young patients with multicentric tumors, and by the time they get diagnosed, they might have metastases. Vipoma, I added it here just because it's exceedingly rare, but in an MRCP exam, one of you for sure will have a question about this combination of watery diarrhea, hypokalemia, and achlorhydria, all due to excessive VIP secretion from one of these tumors in the pancreas. So how we identify these patients? Where do we find these patients? First of all, the most beautiful scenario is if you can clinical decision and assessment of a young patient that presents with 2 or more tumors and has a good history that maybe somebody else in his family had tumors related to MEN1. That is the most rewarding. The most exact needs to be the screening of such families, and that's the second scenario, where you have already an MEN1 patient and now you're checking all the first-degree relatives. And more, because genetic screening and genetic testing becomes more and more used, some patients might be picked up by chance if they get involved in another, for another reason, into a genetic testing, and the test picks up abnormalities in this particular gene. The biochemical screening, promise you it's well over the level of this. I just wanted to show you, but that for each of the glands, it's a certain protocol that starts quite early in life at 8 years, 5 years, 15 years. And these people go through a regular program once a year or once every 2 years to assess for the development of such tumors. So to finish with MEN1, we said that it's the 3 Ps. It's not easy to diagnose on genetics, but has to be confirmed on genetics. And therefore, it's all this understanding of what can be affected to decide what glands needs to be tested, when and how, looking for the development of these tumors. MEN2 was now described only a few years later, completely different arrangement. This time there will be patients who develop a cancer, and that is a cancer in the thyroid gland, and it's a very specific type of cancer called medullary thyroid cancer, the one that produces calcitonin. These are rare tumors. Most of you might never come across one of them. Then the syndrome also involves development of pheochromocytomas, and some of the patients have again parathyroid tumors. The cancer of the thyroid develops in all patients, pheochromocytoma in about half of these patients, and the parathyroid tumors just in a quarter or less. And all appear in young people with bilateral disease. I have to mention this MEN2B, which is the same combination of tumors, but in a young person who also has Marfanoid habitus, and the picture tries to show the asymmetry between the length of the arms compared with the length of the body, and development of these little tumors inside the lips, which are these mucosal neuromas. Now, this is a diagnosis that you need to be able to pick up just by looking at the teenager. Could be a bullied child at school because he looks a bit different than anybody else around. And if somebody can identify the abnormal proportions of the body combined with these strange lips, and at times with the strange discoloration on the back, on the skin on the back, then just by looking at that young person, you pick up a syndrome that puts him at risk of a cancer that will have to be treated in the very near future. So once again, clinical examination, it's massively important for these people. The beauty of this syndrome is that a lot happened during your lifetime. So when you were children, most of those who are listening today, the gene was identified somewhere on chromosome 10. It's of little significance for us if you forget. Very soon, people discovered that a handful of mutations are responsible for this disease. About 2/3 of the patients in the world have mutation in the one codon, 634, and the others are tiny numbers across the world. So now this time it's very different. With the first syndrome, we had 1,300 mutations. Here we hardly have 10 or 15 of them. And what was possible then to do was to move from understanding where in the gene structure it's a mutation, what exact codon it's mutated, and by the way, you don't need to remember any of these numbers. They're widely available on big catalogs. But then to have the concept that knowing where is the mutation, you can understand when do you need to start to look for these tumors and at what age these people need treatment. And this is called phenotype-genotype correlation. So that the mutations are classified in 4 groups. Again, they're all in a book. You don't need to remember, you just need a concept. And depending on which group the mutation belongs, the risk of developing cancer is high or very high. And therefore, the cancer, the medullary thyroid cancer, would occur in adulthood if your risk is sort of lowish, or in the first year of life. The difference is massive. You're moving from doing thyroid surgery in adult, of which there are about 10,000 operations done every year, and there would be lots of people able to do it, to do an operation in a 1-year-old or few months old child, which I don't think there are a handful of surgeons in this country prepared to do it. So knowing the mutation, understanding its significance has a massive bearing on how you advise those parents. And as I said here, many children with MEN2 require operations before age 5. In addition to the medullary thyroid cancer and the prophylactic thyroidectomy, they also need screening for pheochromocytoma, and that starts usually later in life at about age 20, and for the bad mutations at age 8. And for parathyroid, it's of little impact on them. I get over. Even more beautiful, data from Japan showed that knowing the exact codon gives you the age when the most likely age to diagnose the pheochromocytoma, and then they produced another graph I didn't show here when specific mutation in that particular codon, so the letter in the codon that it's affected has some bearings on the age when your pheochromocytoma appears. So that you look at when do I start to think that they could have it, in the at age 10 or about age 30 or much later in life. And surgery for this condition, rare as it is, it's super interesting because you operate on well patients who are yet to have the disease and you do a prophylactic operation. So it's a difficult concept to introduce. Going back in history, Abraham Lincoln, unfortunately, didn't know any of this. So in his days, the concept was not there, but the story goes that he's the most likely the most famous patient with MEN2 based on his body habitus, based on stories of his life, and on the fact that he had these little neuromas in the lips as it appears on a sculpture done around that particular time. His children died early in their lives. His mom died early. It's a suspicion that President Lincoln had MEN2. It will only be a theory. What I know for sure, and I give you an example because I think I have another 2 minutes of my talk, is I'll show you how the story develops in one such family. I met this man in 2008 and presented with medullary cancer. And he told me that his mother died in 75 within a few months of diagnosis. And so I thought, well, that should be also medullary cancer. In those days, it was really difficult to diagnose it. Today, it has to be. Once he was proven to have a mutation, his children been tested, and he had 2 boys aged 30s and a girl in age 28 who was negative. So then I needed to look after the 2 boys. If you remember, by this time, they should have had their operation done if it was to be prophylactic. But they didn't because they didn't know of the condition. So by the time they came to me in their 30s, their calcitonin was high in one of them and was normal in the other one. And at the time of the operation, one of them already had metastatic medullary cancer with all the lymph nodes involved, in addition to his thyroid. And the other brother had tiny tumors with no lymph node involved. And some 10 years later, the dad is still alive, but with metastatic disease. One of the boys is alive, but with metastatic disease that we don't know where it's coming from, but we know it exists because calcitonin is still very raised. And the other son was cured through an operation done therapeutic, not prophylactic. And the only prophylactic girl that we've done here in Oxford was age 4, was diagnosed when her sister, age 20, was treated for medullary cancer in Australia. They done a genetic test on her, found her to have mutation. The little sister in England was tested. I came to operate on her at age 4. So these are the sort of story of MEN2. I hope there would be some questions, and I try to find out my timing of how do I get the questions. Perfect. Thank you very much for listening. And once again, thank you to the college for organizing this.
Well, that was really interesting. Really interesting, Radu. I've got some questions. One from Richard Mifsud. I recognize his name. I'm pretty sure he's a student here in Oxford. And Richard has said regarding MEN1, when you have patients who have tested positive when you're suspicious on the genetic screening, but they don't have any symptoms, do they have prophylactic surgery, or do they just?
No, they don't, because first of all, it's rare to get a cancer. To remove the normal parathyroid glands in a patient will make them hypoparathyroid, which is a very miserable condition to live with. You cannot remove the pancreas prophylactically, and that's why I said they have to enter into a screening program where you hope to pick up biochemical abnormalities or radiological changes in the pancreas early enough to act when the disease is at the beginning without impacting badly on the outcome, but not rushing to operate too early. For the MEN2, you do prophylactic surgery because you try to stop development of thyroid cancer. It's very easy to remove the thyroid prophylactically. You take thyroxine, you replace for good.
Yeah, okay, that makes sense. And if I can ask a question, Radu. So
Yes.
obviously, I mean, this is a complex subject, and surgery is just one part of the management of these patients.
Absolutely.
So, I mean, who else do you need to have involved? Presumably an endocrinologist, a geneticist, and how do these teams normally come together, and how do they work both in the UK and other parts of the world?
The priority is to have a strong endocrinology team with an interest. The geneticist, it's the crucial part of this, but laboratories in genetics are very few around the country. So most people will send samples to these centralized laboratories. It's a huge one in Exeter. We have a very big one here in Oxford. I can't make a list of all of these. But the priority is to think of the disease and send for this genetic testing. A radiologist with an interest in this is crucial. And generally the concept of multidisciplinary team, because nobody would have ever experienced enough to be an expert without this joint collective experience put together.
It must be something that's got an interesting following. I mean, in terms of worldwide, are there conferences specific for MEN, or is it something?
Oh, yes, there is a men congress, which is strange to call it the men congress because I think people on the street will think women are not allowed. And this is the wrong time.
Yeah.
Yes, there is every few years, it's an MEN meeting somewhere around the world. Was one in Vienna about 4 years ago and was one last year in the US at the MD Anderson. And the interest in the condition is huge because the basic science behind this, it's immense.
Yeah, well, it seems absolutely fascinating. I've got another question about the MEN2 and those characteristic lesions which are seen in the.
Yes, I found that these students are really amazing. They challenge me more than I want to be challenged.
Yeah,
about
tricky question sometimes, eh, Radu?
A fantastic question, whether if you see neuromas, does it mean that they have straight away MEN2 or could that be something else? I think it's a combination that makes the diagnosis. One element on its own, it's not enough for anything. So when I mentioned that if you see the child that looks a bit strange proportions because he's marfanoid and with those big lips and with the spotted skin on the back, they need to be somehow together. Neuromas on their own, yes, you can have neurofibromatosis type 1, and they are again quite spectacular patients for us. And there is a clinic here in Oxford that sees only patients with neurofibromatosis. I get to see them every now and again because they also can have pheochromocytomas. So neuromas on their own are not a hallmark just for MEN2. But when you see it, you have to think, hold on, do I find something else in addition to the neuroma to start to make a package that I can label suspicious of MEN2?
Yeah, okay. Well, I think we're probably just run out of time, I'm afraid. Well, that was absolutely fascinating, and I learned a lot this afternoon. Thank you very much indeed.
Well, thank you to everybody. The questions were lovely, and as I say, shame I can't see the eyes of those who listened to sort of change the pace as we went along. But once again, thank you. I have 2 more lectures on pheochromocytoma and Cushing sometimes later, and I hope to meet most of you once again. Thank you for today.
Well, thank you so much. So the next webinar is on the slide in front of you, which will be on acute pancreatitis on Thursday, the 25th of June at 4 o'clock. Do we have a speaker for that yet? Oh, no.
Sorry, I don't have a speaker to hand, unfortunately.
Don't have a speaker. Okay, good. Well, thank you very much, everybody, for listening this afternoon. And